I'm Hopkins, and I am one of the co-leads of the Community for Global Health Equity, and I'm the director. And I'm really thrilled to introduce Dr. Christine George, who is visiting us today from Johns Hopkins University. And Dr. George got her PhD at Columbia University and has been an assistant professor at Johns Hopkins now for several years, four and a half. And has been doing a lot of really terrific work in the areas of water sanitation and hygiene, and the prevention of enteric infections, and looking at the mechanisms involved in the transmission of pathogens, but also in changing the nutritional risk factors for young children in a place like Bangladesh, where about 30% of kids, right, are stunted. It's a huge burden of disease, and so these are really critically important work that she's doing. So thank you so much, Christine.
Thank you for the great introduction. So as Dr. Ram said, I'm Christine Marie George, and I'm a faculty member at Johns Hopkins in the Department of International Health. And my research really focuses on identifying transmission routes for environmental exposures and then developing interventions to intervene upon those exposures. And so I'm currently directing 3 randomized control trials. One is actually based in the US, and it's delivering arsenic interventions in American Indian communities. So really taking a participatory approach in terms of conducting intensive informative research phase, where our native-owned research organization that we're partnering with is conducting in-depth interviews in the community, as well as doing piloting and group discussions. And then the second randomized control trial is in Bangladesh, and it's actually on diarrhea patients and their family members, and how we can use the time that patients spend in the hospital as an opportunity to deliver WASH messaging. And then the third randomized control trial is one that we're starting up now in the Democratic Republic of the Congo. And it's actually related to what I'm going to talk about today, and how to reduce environmental enteropathy in susceptible pediatric populations. And so how to reduce ingestion of enteric pathogens both through dietary routes as well as non-dietary routes. And so today's presentation, I'm going to talk about a collaboration between our research group and the International Center for Diarrheal Disease in Bangladesh, which I'll refer to as ICDDRB, where we investigated risk factors for environmental enteropathy and impaired growth in communities in rural Bangladesh. And so an overview for my presentation is I'm going to start by giving background on undernutrition, and then I'm going to talk about environmental enteropathy, child feces disposal, talking about geophagia, and then going into our study design, results, and conclusions. And so, as I'm sure many of you know, undernutrition is estimated to be the underlying cause of death of over half of young children globally. And at the time that children are most susceptible is during the first 2 years of life. And so in this figure here, the x-axis is showing the age of the child, and then the y-axis is showing their WHO, the World Health Organization, growth standard for their height and their weight. And so in blue is the height for AUC scores. And so you can see during the first 24 months, you're seeing a dramatic decline in terms of the height of the children based on their age. And so what is environmental enteropathy? Environmental enteropathy is defined by this blunting of the intestinal gut microvilli. And so here I show 2 biopsies. On the left side here is a healthy intestine, and these are your gut microvilli. You can see they're protruding. And then on the other side here, you're seeing someone that has environmental enteropathy, and so they're blunted. You're not seeing them protruding in the same way that you see in the other biopsy. And so the causal pathway by which environmental enteropathy is thought to lead to impaired growth is through chronic inflammation and then low nutrient absorption. And so the gold standard to measure environmental enteropathy is through endoscopy. And so this involves sending a camera, a scope down, looking at the small intestine, and then collecting a biopsy. So you can see the slides that we're showing here. But as many of you know, in low-income countries, this is typically not practical to be able to do this. And from my standpoint, doing it in a large population is not ethical, especially if there's no clinical reason to do this. so there's been the recent emergence of proxy measures of assessing environmental enteropathy. And so one test that I won't mention in my presentation today that you may hear is the lactulose mannitol test. And so it's giving people a sugar and then measuring their urine or collecting their urine over a 5-hour period. However, for small children, that's often difficult to do because you have to use urine bags. As you know, small children are running around. And so in our study, we focused on these fecal markers of environmental enteropathy. And so for alpha antitrypsin and myeloperoxidase, these have been validated as measures that are used for inflammatory bowel disease. And this is inflammatory bowel disease that's been confirmed by endoscopy. And then for neopterin, this is thought to result from cell-mediated inflammation in the intestinal tract, and it's been highly correlated with celiac disease. And so celiac disease has a different mechanism. It's autoimmune, but it has a similar presentation. So for celiac disease, you're also seeing this blunting of the intestinal gut microvilli. And so these different fecal markers are measured using ELISA assays in the laboratory. And so recently, an investigator at Johns Hopkins, Dr. Margaret Kosick, developed this environmental enteropathy disease activity score, where she combined these 3 markers together to form a more comprehensive measure of intestinal inflammation. And so in her recent article, she was able to associate high environmental enteropathy disease activity scores with linear growth deficits in children. And so the causal pathway by which environmental enteropathy is thought to occur is that you have these unsanitary environmental conditions, such as poor sanitation. You have animals running around that are leaving feces behind. Then susceptible pediatric populations are ingesting these contaminants. And we'll talk about some routes for that later. That this constant assault by enteric pathogens is resulting in environmental enteropathy. And then the chronic inflammation and the low nutrient absorption is leading to impaired growth. Are we open for questions? If people have questions during the presentation, so if you have questions, please let me know if something's not clear. And so when people are thinking about exposure routes, very often they're thinking about the F diagram. And so that diagram works as you have your diarrhea, and then you have your routes for which this is causing exposure to people. So each of the F's is showing an exposure route. And so the newer versions of the F diagrams are now talking more about fomites and toys and soils and things people can become exposed to, as well as things that are traditionally in the model of food and fingers and fluids. And so for the first part of the presentation, I'm going to talk about child feces disposal and how that is an exposure route to enteric pathogens. And so the idea is that if a child defecates in the open and the feces isn't disposed of safely, that this could actually affect all of these routes and then lead to exposures to other susceptible pediatric populations. And so the Joint Monitoring Program defines safe child feces disposal as disposal of child feces in a toilet or buried, and any other method is considered to be unsafe. And so there was a recent report that looked at 15 countries and saw that over 50% of households with children under 3 years of age were disposing of child feces in a manner that's unsafe. And so there's a very limited body of literature, but the information that we have available suggests that this is leading to fecal exposures in the population. And so a study a few years ago in Bangladesh was able to associate this behavior of unsafe child feces disposal with soil-transmitted helminths. And another meta-analysis that was found showed that this behavior was associated with a 23% increased risk of diarrheal disease. And so going back to our F diagram, the next route I'm going to talk about is fomites. And so as I mentioned before, fomites can be toys, it could be objects, or it could be soil. And so one of the risk factors that I'll go through today is looking at soil as an exposure route to pediatric populations. And so in particular, a behavior that we refer to as geophagia. And so geophagia is consuming dirt, soil, sand, clay, or mud. And so anyone that has a small child knows that during the first 2 years of life, they're putting everything they come into contact with in their mouth. They're putting the dirt, their fingers are going in. And so if this is contaminated, it could be a route for exposure. And so this is a risk factor that we're gonna look at today. And so there was a study done by the SHINE group, which you closely worked on, that looked at geophagia in a pediatric population in Zimbabwe. And so there they saw that infants were actively ingesting soil as well as chicken feces. And so when we focus our attention on dietary routes like water, when children are ingesting feces, think about which one may have the larger impact on the child's fecal exposure. And so there's a growing body of literature demonstrating an association between this behavior and exposure to fecal pathogens. And so there were 2 studies in Kenya. One study found that this behavior was associated with diarrheal disease in children that were under 5 years of age. And then the second one showed that this behavior was associated with soil-transmitted helminths. And then there was some work in Tanzania that showed that the pathogenic E. coli was present in the soil. And so the causal pathway that we're proposing for the analysis I'm going to show today is that unsafe child feces disposal is leading to environmental contamination in the child's play space. The child is then going to ingest these pathogens through consuming dirt and other fomites, putting them in their mouth that's in their environment. And something I should know is in the context of child feces disposal, in Bangladesh, people live in compounds. And so you'll have several households that are on the same compound. And typically that means you have multiple children that are under 5 years of age. So if one child is sick, they have the potential to then make other children within the household compound ill. So we propose that they're ingesting the fecal pathogens. This then leads to an environmental enteropathy and then the impaired growth.
So are you particularly focused on just baby feces disposal or any sorts of, because you could also have contamination from livestock feces?
You can. So there's many routes. And so today I'm focusing on the child feces disposal, but we've done other work where we looked at just what you were saying. And so animal feces, most of these household compounds have animal feces. They may have chickens that, for example, we asked people if they had chickens and they said no, but we see chickens running around and they said those are the neighbor's chickens, those aren't our chickens. And so that's definitely a route. And we actually found, but I won't talk about today, is that if a child that's living in the same sleeping space as an animal had higher environmental enteropathy disease activity scores. And so that's definitely an important route, but today I'm focusing on the child feces disposal. And so the objectives related to the child feces disposal was determining the prevalence of the behavior, so disposing of the child feces unsafely in rural Bangladesh, looking to see if this increased fecal contamination, so comparing households that practice safe child feces disposal to those that didn't, in terms of the amount of pathogenic E. coli that was present in the soil. And then looking at the relationship between this behavior, environmental enteropathy, and impaired growth. And so for geophagia, we were interested in looking at the prevalence of the behavior in our study population among children, and then looking to see if this was actually an exposure route to enteric pathogens, and then again determining the relationship between this behavior, environmental enteropathy, and impaired growth. And so our study site was rural Mirzapur, Bangladesh, which is located northwest of Dhaka, and it's the home of the Global Enteric Multi-Center Study, which you probably have heard of as the GEM study. And so they followed 240,000 individuals for different outcomes. And so we randomly selected children from within this demographic surveillance system for our area, for our study. So this is highlighted in pink. And so it was a prospective cohort study that we conducted, and we randomly selected 216 children. And so this was based on how many people we could recruit over a 3-month period within the population. We conducted a baseline survey where we administered a questionnaire tool to get household demographic information, as well as assess caregiver reports and observed child feces disposal practices, as well as geophagia. And I'll talk in more detail about this shortly. And And we also collected a stool sample and a soil sample. And then we followed up with these households 9 months later and collected anthropometric measurements as well as questionnaire data and spot check. And today we haven't gone through and analyzed it, but we still have been following this cohort. So they're getting close to their 2-year follow-up. And so for our geophagia assessment, we conducted 5-hour structured observation as well as obtained caregiver reports. And so we did this for a couple of reasons. We wanted to actually look at observed behavior, and we also wanted to see if caregivers were able to accurately report on observed behavior. Kind of a validation of this measure. And then for child feces disposal practices, we conducted 5-hour structured observation, and we also obtained caregiver reports on the behavior. For soil testing, we focused on the child's play space because this was really our interest. This is where the child is spending most of their time. And this typically was the household compound, the outdoor space. We were measured for pathogenic E. coli by PCR, and we also performed E. coli counts. We looked at the fecal markers and environmental enteropathy that I mentioned earlier, the diopterin, the myeloperoxidase, the alpha antitrypsin. And we collected the growth measurements and calculated WHO child growth standards. And so now I'll focus on our risk factor looking at the unsafe child feces disposal. And so when we observed these children for 5 hours, we found that 36% had a defecation event. And that the most common behavior was open defecation. And a very small proportion used a potty, and one child had a caregiver help them. We found that 84% of caregivers had an observed unsafe child feces disposal event. So during structured observation, we saw them disposing of the child feces unsafely. When we looked at caregiver reports, it was 75%, so they were rather close. And we found that 91% of the observed events were also caregiver reported. And so it showed that caregivers were able to give accurate reports on this behavior. And so we found that the most common way to dispose of the child's feces was in an area adjacent to the household compound, so in an open space that was thrown. The next thing we were interested in is in our rural Bangladesh context, all these households had a sanitation option. And so we divided it using the joint monitoring program definition between improved versus unimproved. And we actually didn't see a significant difference. We thought maybe households that had unimproved would have greater unsafe child feces disposal, but we didn't see that.
What was defined as improved versus unimproved?
So the joint monitoring program defines it as a separation between human feces in contact with humans, and so they would have to have a ring, a concrete ring with a cover on it for defecation. So something like a flying toilet where they're throwing it, or a hanging toilet, that wouldn't be considered an approved sanitation option. Or if the concrete ring was broken, that wouldn't be considered safe either. We also looked at age. So we thought that maybe as kids got older, that the caregivers would dispose of the child feces more safely. But we didn't find that either. And this is both for the observed and the caregiver reported behavior. Next, I was going to go into our soil results. So we looked at the presence of E. coli, and 97% had detectable E. coli. I wasn't really surprised by this because there's been some studies that show that E. coli can occur naturally in the environment. But we also looked at quantitative measures. And so when we looked at the geometric mean of the E. coli counts, it was 7,028 colony forming units per gram. And to put this into context, in the SHINE study, their geometric mean was around 2,000. So ours was much higher than what they have reported. And then when we looked at pathogenic E. coli, we found that 14% of the households had detectable pathogenic E. coli in the soil in the child's play space. So this showed that the soil was an exposure route to pathogenic E. coli in this population. The next thing we did was we stratified this between households that practice safe child feces disposal, this is the pathogenic E. coli results, and those that didn't. And so we saw that in the households that practiced unsafe child feces disposal, they had more than a 5-time higher odds of having pathogenic E. coli being present. The next thing we looked at was the environmental enteropathy.
That was a very wide confidence interval.
It was, and it wasn't significant either.
So, any thoughts on what that might be due to?
I think our sample size was small. So we only had a total of 28 kids that practiced safe child feces, 28 households, and then we had 100 households here. And so in our upcoming work, we plan to have a larger sample size to be able to look at that more closely.
So it's a per household, not per child analysis?
This is per household. So households with safe child feces disposal and the households with unsafe.
So you found that the compounds or households where one family practiced safe feces disposal, others did so as well, or
so there were only 1 or 2 households where we had multiple children, and
Okay.
I would have to look back at the data to see if it was concordant. Did you have a question, Whit? Okay. So the next thing we looked at was caregiver-reported feces disposal and our environmental enteropathy disease activity score. And so here we saw children that were in households where there was unsafe child feces disposal had significantly higher environmental enteropathy disease activity scores. So this is a model where we also included the Geophagia results. So this is showing both risk factors in the same model.
Which factors are important to come up with the score?
I'm sorry, can you say that one more time?
Yeah, the environmental enteropathy score is based on what kind of?
So it was based on 3 markers. So the alpha antitrypsin, then the opterin, and the myeloperoxidase. So those 3 markers. And so the next thing we looked at all different growth measures within the children. So we looked at stunting as well as underweight. And for this particular risk factor, we found that wasting was a factor that was statistically significant. And so we actually didn't find any households that had children that were wasted that practiced safe child feces disposal. And it was 9% in households that practiced unsafe child feces disposal. So in summary, consistent with previous studies, we saw a high prevalence of unsafe child feces disposal in this population. It was greater than 70%. We found that households that practiced unsafe child feces disposal had higher environmental contamination. Our sample size was small, but the difference was large between the 2 groups. Next, we found that unsafe child feces disposal was associated with environmental enteropathy disease activity score, as well as impaired growth in this population. So now I'm going to go on to our next risk factor, which is looking at geophagia. And so again, geophagia was assessed using 5-hour structured observation as well as caregiver reports. Did you have a question?
I just want to make a comment, which is that you showed that it was in soil, right? That the colony, your contamination level was so high, greater than 7,000 colony forming units. Hand hygiene, which we've taken to be like the thing that is going to prevent so much infection, we often find in a Bangladesh environment or in other places like this that are unsanitary that hands have maybe 10 to 25 to 50 CFUs.
Oh wow, so just much higher.
The remarkable difference in the exposure in soil, I think should just be very evident, that hands pale in comparison to what kids are being exposed to in soil.
And they're ingesting it, which we'll talk about next. It's important.
One thing I was going to ask is how much does the inoculum matter? Is there a threshold beyond which the inoculum does not matter anymore? Is there a difference between, say, having 20 colony from a unit to having 200 colony from a unit?
And so I think the question is we don't know. And that is a body of literature that's evolving over time in terms of the inoculum size needed to cause environmental enteropathy. I don't think that's well defined right now. So now I'm going to go into the geophagia data. And so this is looking at the structured observation as well as the caregiver reports. And so we saw that the structured observation results was 18%. in terms of observed geophagia, and then for caregiver reports, this was 28%. The next thing we did was break this down by age. And so looking at structured observation from children that were 6 to 12 months of age to 24 to 30 months of age. And so when you look at the child psychology literature, you see that it's the first 2 years of life where children are exploring their environment the most, when they're putting everything they come into contact with in their mouth. And so we expected to see a decline in this behavior over time, which we did in fact see, both in the structured observation and in the caregiver reports. And we saw this behavior was the highest during 6 to 12 months of age, which is consistent with this, but it's also consistent with the literature around child teething. And so children are teething substantially between 6 to 12 months of age, and often they're putting something in their mouth to alleviate that pain. And so we think that both of these are probably contributing to the higher rates of geophagia we observed during this time period. And you can see that after the 6 to 12 month period that this then declines. So we looked at the association next between geophagia and environmental enteropathy disease activity score. And so here we saw that again, this model also includes the unsafe child feces disposal variable, that this behavior was associated with elevated environmental enteropathy disease activity scores. Do you have a question? I thought you had a question. And then we looked at stunting. And we found that this behavior was associated with nearly a 2 times higher odds of stunting for children in the population. And again, you can see what we adjusted for here in the model. And so in summary, these findings demonstrated that mouthing soil was something that was happening within the study population in common, particularly for children that were 6 to 12 months of age, where we have 50% caregiver reports of the behavior. We found that geophagia was associated with an environmental enteropathy disease activity score, and also was associated with 2 times higher odds of stunting. And then we also demonstrated that it was an exposure route to enteric pathogens in the previous data I showed you from the unsafe child feces disposal data. So in conclusion, these findings suggest that unsafe child feces disposal increases environmental contamination in the child's play space, that geophagia is a direct exposure route to enteric pathogens in the environment, and that both behaviors are associated with elevated environmental enteropathy as well as impaired growth. And so that concludes my presentation today, and so I'd like to open the floor for any questions that you have. And I also want to acknowledge our research group. So this is our field team that's based in Mirzapur that helped to conduct the 5-hour structured observation. I'll never forget when I was telling the PI there, Dr. Ayesha Farouk, that I wanted to watch kids eat dirt for 5 hours. And it took me a long time to explain to him why this was important. He didn't get the point. And then also explaining it to our team on the ground. And so they spent a lot of time doing this, and people who know the Bangladesh context, we conducted this between February and April, and that was the hot time of year, so it was really hot, and they were out there for 5 hours watching the kids. And then below is our field, our laboratory team that's based in Dhaka that contributed substantially to the work. So I'd like to thank everyone and open the floor for questions.
For the team members who observed the children for 5 hours, were they all women, or do you have male members in the team?
We had male and we had female. And so we looked at that in terms of the rates of events that we were observing, and we didn't see a difference across the different genders. Yeah.
But do you suppose the activity could be different between female staff and male staff?
For children, we wouldn't necessarily expect that to be the case, but for the child feces disposal practices, it could be. But we saw that safe disposal was very low, and we didn't see a difference between the gender of the observer. That's a good question. Were there other questions?
Yeah. In the households that practice safe versus unsafe child feces disposal practices, do you have any idea for the difference of why those households did what they did?
So I think a risk factor analysis is needed, and we haven't done that to see if maybe the educational level was lower in households that practice unsafe versus safe, and so I think we should definitely look at that.
I mean, in general, in Bangladesh and a lot of South Asia, there's less risk perception associated with child feces versus adult feces.
That's an important
And
point.
That's a really important cultural explanation for why people, first of all, allow kids to defecate wherever they choose, but also for leaving that feces there and not sort of rapidly coming up after the child and cleaning it up.
And I should also mention we had data on that. So only 14% of caregivers were observed stopping the child when they were consuming dirt. So it was very low. But when we asked them what they would do, 72% said they would stop the child, but only 14 were actually observed doing that. So that showed a contrast between the two. But people perceiving that child feces is more safe than adult feces is definitely an issue in terms of disposal practices. They don't feel the need to dispose of it in the same way. Were there other questions?
No, so in Bangladesh, children wear diapers or not?
So for the most part of this population, they weren't wearing diapers.
Even potties are really not used that much.
Yeah, I remember I was in the slum a couple of weeks ago, and the people from another house were saying they had that potty, but we never see the child using it. And it was a very fancy one. It was one of the ones that shaped like a duck.
Oh, yeah.
Yeah.
No, there was one study that was published a couple of years ago. They compared two populations within India, and the populations were the Hindu versus the Muslim in India, and they noticed differences in diarrheal disease in children that were striking between the Hindu versus the Muslim, and the main difference was because apparently the Muslim wouldn't do more open defecation in comparison with the Hindu.
Interesting.
But I don't know, in Bangladesh everybody's Muslim, right?
So there is a Hindu population, and we haven't stratified it. When I was a doctoral student, when we looked at arsenic, we had this strange finding that Hindu communities tended to switch more than Muslim communities, but we were never actually able to explain that. So I'm not sure the reason for that finding.
Good question. So you mentioned the duck potty and how they had the duck potty, but it wasn't even being used. So in thinking forward with creating some sort of intervention so that people won't practice open defecation, if it's something that is just done and it's just the norm, what type of intervention is going to change that so that households and people around a community are going to stop doing what they've always done?
So I think that's a great question. And what I would say is the first thing is informative research. To go through and do in-depth interviews with the women, understand more of their perceptions around the child's feces, around what they think happens when they dispose of the feces, and then from there to tailor interventions that target that. Were there other questions?
You mentioned that I think you did your soil sampling during the dry season.
So the hot season,
Hot season.
but there's less rain that time of year.
Yeah. Do you think there's any seasonality?
So it's definitely possible. With the soil sampling, we're actually planning to go back and do additional soil sampling. I think it's higher than this. And I think it's higher than this for several reasons. Because we found we found feces on basically all these compounds. And so I was actually surprised that the pathogenic E. coli was this low. And so I actually came back from the UNC Water and Health meeting 2 weeks ago, and I met a person that he said that I can help you to find campy in the soil. And so we're planning to collaborate together to try to detect campy in the soil. I know it's there. We can't measure it.
With that many chickens.
Yeah, with that many chickens, we know it's there. And so hopefully I can report back later and tell you if we were able to find that.
Yeah, I think that would be really interesting because there's so many studies that show seasonality to child growth that you wonder if there's maybe linkage.
That makes sense.
Yeah.
And so I should say Campylobacter. So I call it campy, but it's Campylobacter.
My other question was, in terms of the geophagia, is there any kind of sort of cultural understanding of desirability of consumption of what we consider non-food?
We had a Likert scale question. Do you think that eating soil is good for your child's health? So we asked that, but only 14. It was I think it was 12% of people said they agreed. So that's not the issue there. And so again, we need formative research to be able to look at that more closely. And so the study that we're proposing and that we're planning to roll out early next year in the Democratic Republic of the Congo, we're going to have a very intensive formative research phase that's going to allow us to look at these things more closely in this new setting.
What's your link to the DRC?
So the idea is that we have a partner that's working there, and they're really interested in baby wash. But they want to take a different approach than previous studies that have targeted, have provided toilets, that have given playpens, and that have focused on water treatment as well as hand washing. But instead, first look and see what risk factors are significant in their population, and then tailor interventions from there.
So, the EE score, do you want to say something about how it's been validated and how robust that algorithm is?
So I can go through the markers again. So for alpha antitrypsin and myeloperoxidase, this has been validated in terms of looking at inflammatory bowel disease, which was confirmed by endoscopy. And then for the neopterin, it's thought to be caused through cell-mediated inflammation, and it's been highly correlated with celiac disease. And another marker, which I didn't show here today, is calprotectin. And so calprotectin has been associated with mucosal inflammation in children, and it's also been confirmed through the endoscopy. But there's really the need going forward for studies that look at endoscopy, that conduct endoscopy, and then look at the lactulose mannitol test, and then look at the fecal markers and compare them. But again, in my opinion, from an ethical standpoint, doing endoscopy in healthy children, I'm not so sure about that.
Yeah, I mean, I don't think you should, well, I'm not sure where I stand on the question of doing endoscopy in children, but...
In healthy children.
In healthy children. When I look at the COSEC paper, it feels like the assumption we make in saying that the EE score is valid is to say that we already know that these pathophysiological mechanisms are actually, we're defining EE as the presence of those pathophysiological mechanisms. As saying that if there's microbial translocation, we're defining EE as those pathophysiological mechanisms itself, because the COSEC paper, I don't know of any process where the EE score has been validated against, say, the endoscopy findings or clinical parameters.
So the score itself has it, but the individual markers have. And so in the papers that we publish, we also report on individual markers, which were also significantly associated with these different risk factors.
That is my concern.
Were there other questions?
No, one question. This study would be considered cross-sectional study, in which you look at the population once, or they had follow-ups later?
So they had a follow-up at 9 months for measuring the child's growth. So that allowed us to be able to look at impaired growth.
Okay, great. And then, were you able to collect information regarding episodes of diarrhea?
We did. And so one of my students is writing a paper now where he's looking at that. And so we had some interesting findings. We didn't see the strong association with diarrhea. And I actually think that's consistent with the literature, that we think environmental enteropathy is more of these constant assaults, and some of them may be asymptomatic. And so we found that diarrhea wasn't significantly associated.
Because it's probably a polymicrobial exposure, right? You're getting exposed to multiple organisms repeatedly over time. Maybe no one is at a sufficient enough concentration to cause infection necessarily, but you're always having that low dose exposure. So you don't have the fluoride infection, but you have the changes in the distal gut.
And that's exactly what we think is occurring. And so it was confirmatory for us that it wasn't associated. And so hopefully he'll submit that in the next couple of weeks.
And just a technical question. So I know that you were obtaining samples from soil to determine colony counts. Now when we do that in water, maybe easy because you can say in 1 cc of water you will have this many.
We weigh it. Is that your question?
Yes.
We weighed the soil.
Also, you weighed it.
We did weigh the soil.
Okay.
Before we did the counts. And something else also that's not included in this presentation, because I didn't want to steal the thunder of my graduate student that's working on it, is we found that fomites were really important. And fomites coming into contact with soil was also associated with these fecal markers of environmental enteropathy. And when we look at the mouthing of the soil, that was 33% overall. But when we looked at mouthing of fomites, it was like 65%. So it was much higher.
So which objects were you looking at?
So we found that kids were putting bottles in their mouths. They were putting the sticks. What were some other ones? Like wrappers and things were going into their mouth. Not so many toys, but those other objects we found people were putting in their mouth.
Thanks for your presentation. Just one brief thing that's just in the news here in the U.S. is just that we should eat dirt because somehow we're going to find antibiotics, and it really is not as unhealthy as maybe we heard, you know, over the years. But coming back to this child eating behavior, what about adult soil eating behavior? Is there any adult soil eating behavior that goes on?
So we definitely know that's the case. And I actually have another slide here where I talk about geophagia and micronutrient status. And so that's always a concern. Is it exploratory child play behavior or is it a micronutrient deficiency? And so there were some studies that were conducted, but none of them were able to establish a causal relationship between geophagia and micronutrient status. There were 2 randomized controlled trials that actually gave iron supplementation to children who were exhibiting geophagia, and they didn't see a significant reduction in the behavior. Oh, did you have a question?
I did, yeah. Actually, it's you said one of the questions that you posed people was if they felt that the soil eating behavior was healthy for the children.
It was healthy for the children.
Was there a follow-up question about what the belief was, like unpacking it, what about it was healthy?
No, but we've tried to submit so many grants for formative research in Bangladesh, and they don't want to fund us. And so I really think that that's the next step, to really do in-depth interviews and learn more about the perceptions around the behavior in these communities. And so I think one of my graduate students is interested in doing some pilot work. So we'll have some data on that, hopefully to present in the future.
Because, I mean, geophagia is perceived to be a really positive benefit in some cultural contexts, like particularly for pregnant women.
That's what I was wondering about.
Right.
Yeah.
Even though there is this high degree of exposure. But for young kids, it isn't clear that those same drivers are there.
Yeah, I agree that we need a more in-depth question to look at that. We kind of included that in our existing work, but I think that should be a whole other study.
But geophagia, I mean, it depends on what you're eating, because there's different types of soils, and some pregnant women, you know, that there's been some formative work to show that, you know, they go to specific places and fix specific types of, it's not even necessarily soils, but these softer rock type clay, exactly. And so, and apparently it's, you know, others in that culture practice that as well. So it's not just a simple.
You're right. Yeah.
And I actually did see.
So it's not always geophagia. It's
Yeah.
And I did see a study in Bangladesh that looked at that. It was an older study that looked at geophagia among pregnant women. Were there other questions? All right, thank you so much. Oh, I'm sorry, one more question.
So quick question. I can imagine that when you're asking to observe and kind of, in a way, almost critique someone's childbearing practices, that can be kind of a touchy subject. So could you just discuss how you approach these women and how you have to recruit them?
You sound like one of the reviewers. Reviewers on our paper. So they asked us that, and what we did was we didn't tell them that we were going there to see your child eating dirt, or we weren't there to watch how you dispose of the child feces. We just said that you saw that woman that was here. She wants to learn more about rural Bangladesh, and so we're observing their household activities. So we never mentioned exactly what we were looking at to the participants. All right, thank you so much.